Hey, good morning or good afternoon, everyone. My name is Karen Curry, and I am the new president for CHNC for 2023-24. Really pleased to welcome you to this webinar series of the Community Health Nurses of Canada. And we've been having great success with our webinar series and looking forward to having you share and contribute to this session today. Today's session is System Transformation, Positive Disruption to Address the Structural and Social Determinants of Health and Advance Health Equity. And we're very grateful to have Dr. Claire Betker here with us today. She's a wonderful friend and advocate for community nursing and nursing in Canada. Before we move forward with our webinar, I'd like to acknowledge my land and where I am coming from. I acknowledge the privilege to live, work, and play in Mi'kmaq, the ancestral and traditional lands of the Mi'kmaq people. I also acknowledge and respect the peace and friendship treaty signed in this territory. So while we meet today in a virtual platform, I'd like you to take a moment to acknowledge the importance of the lands that we each call home. So please take an opportunity in the chat to share and acknowledge the traditional lands that you are calling from. I think it's also important for us to reaffirm our commitment to our responsibility to improving relationships between nations and improving our own understanding of the local Indigenous peoples and their cultures. From coast to coast to coast, we acknowledge the ancestral and unceded territory of all Inuit, Métis, and First Nations people that call this land their home. So again, I join you to take a moment in the chat box to acknowledge the territory that you are calling in. And this in our own way is a part of us as community health nurses to try to move forward in a spirit of reconciliation and collaboration. So please take a moment to reflect and put in your land acknowledgement. So I'd like to, on behalf of CHNC, welcome you to this webinar. CHNC tagline is "We are leaders for a healthy Canada," and I know where each of you are coming from. I'm sure you're doing amazing work in your communities, in your health units, whether it's public health, home care, or family practice nursing. Community Health Nurses of Canada is made up of roughly almost 300 members, and we're certainly open to growing and having you come and share in the work that we're doing. We have 10 active standing committees, small but mighty, that are doing great work in promoting the values and strategic plan for Community Health Nurses of Canada. So really grateful that you've taken time out of your busy work days to attend and share with us today. I want to make you aware that we are in the beginning process of planning our Community Health Nurse Conference for 2024. We're looking at venues in Ontario and working to finalize the date shortly. So as conference planning is beginning, if that's an interest to anyone to be part of that, to share your voice, please feel free to email me your intentions. There's a couple of committees, the program committee, sponsorship and marketing, and our hospitality committee. So thought I would make that known up at the top of the session there today. And just an overview of who we are, and this is a brief from our strategic plan outlining what are the goals and objectives that we're trying to do to be the voice of community health nurses in Canada. And our three objectives are to advance the health of people in Canada, to strengthen CHNC as a center of excellence in community health nursing, and importantly, to build an effective organization. So we welcome and invite you to be part of this organization and the work that we are doing. So really pleased to have Claire take time out of her really busy, wonderful schedule and work that she's doing to support the health of all Canadians. Claire has been a friend to VON, and I'll just go over her bio here. Claire is an RN and the scientific director of the National Collaborating Center for Determinants of Health. Claire was previous executive director of the Population and Public Health Branch, the Department of Manitoba Health, Seniors and Active Living. Claire has had a career that has included roles in rural and urban public health, home health, primary health care, regional health authority, and with the Public Health Agency of Canada. Claire is a past president of the Canadian Nurses Association and of CHNC. Her PhD work focused on the capacity of public health leadership to advance health equity. Claire brings a wealth of expertise, rich networks, and a passion for translating knowledge and evidence, especially to the position of public health and the role of the community health nurse in advancing health equity. So over to you, Claire. I will stop sharing my screen and allow you to share your screen, and we'll keep moving on.
Thanks so much, Karen, and congratulations on your position as president. I think today's your first day. Is that true?
Today's my first day, yes.
Well, I'm proud to be a past president with you, and we were reminiscing as we got ready to come into this session that we met a long time ago, started our relationship in Halifax. I think at Pier 21, I remember you doing some clog dancing. So I wish you well. I think you're a great choice for this time right now as a president and of the Community Health Nurses of Canada. And I'd really invite you to bring your energy and passion into that role. For me, it was a significant milestone and step in my career, and I'm proud to call myself a past president of the Community Health Nurses of Canada. So I'd like to start by acknowledging that the land from which I am speaking today and from which I work and live, I'm in Treaty 1 territory, and that's the traditional territory of the Anishinaabe, the Cree, the Oji-Cree, the Dakota, and the Dene people, and the national homeland of the Red River Métis. And I'm grateful to be here in a beautiful piece of the center of what we know as Canada, in Manitoba, in Winnipeg. So I'm just going to ask that you can see my screen. Can you, everyone?
Yeah.
Pardon me?
Yes,
we can see it, Claire.
Yes, it's good, Claire.
Yes, we can see it. Yeah.
Okay, perfect. Okay, so I have, I'm going to just test the slides, make sure that they move forward here for me, because I no, I knew that was going to happen. Okay, so we rehearsed this, we had it working. I don't know that I can get where I need to go. Shoot, just a minute. Oh, there we are. I found what I want to be. Okay. So I just want to give a land acknowledgement for where the center, where the National Collaborating Center for Determinants of Health is located. And it's similar, it's the same unceded lands, ancestral and unceded territory of the Mi'kmaq people, where you gave your acknowledgement, Karen. And that territory you mentioned is covered by the Treaties of Peace and Friendship, which was signed by the Mi'kmaq and the Wolastoqiyik peoples in 1725. And those treaties did not deal with surrender of lands and resources, but in fact recognize the Mi'kmaq and the Wolastoqiyik people's title and establish the rules for what is an ongoing relationship between nations. But I also think it's important to acknowledge and to remember that these treaties were established at a time when Black people, forcibly brought to Turtle Island through the transatlantic slave trade, were enslaved or were fleeing from being enslaved in what is now known as Nova Scotia. So it's important to acknowledge that history, I think, as well. So we set some pretty tall learning objectives for today's session, talk about inequities, especially those that were exposed by the pandemic. We knew they were already there, but and they were exacerbated and I think made manifest. Talk about system transformation and where there's opportunities for positive disruption. And we had some chats in our planning committee as we got ready for today's session about what that means. Explore the distribution of power and its influence on whether it's system or social transformation. And I really don't know that we can talk about equity and or inequities without some very serious consideration of power and power imbalance and power redistribution. Learn about approaches or levers or strategies that influence systems. And then I think about, probably being more of a reflective learning objective there, what community organizations, what partners, who's in our communities and in our spaces that can work with us in that positive disruption for and towards system transformation. A little bit about us, for those of you who don't know about the National Collaborating Centers for the National Collaborating Centers for Public Health. There are 6 of us across the country, all hosted by either an academic institution, ours is St. FX University in Antigonish, Nova Scotia, or by a provincial government in the case of Healthy Public Policy in Quebec, and the Centre for Environmental Health in British Columbia. And each of us has a focus and a topic. And interestingly enough, we were put in place post-SARS, so in and around 2005. So coming on to 20 years, and in a couple of years, by the time we're finished with this funding cycle that we're in, we will have been in existence for 20 years. So having, I think, some pretty solid history and expertise in the topic areas that we've been working on. We have 3 primary goals or mandates that collectively, as a program funded by the Public Health Agency of Canada, that we focus on. First of all, to identify knowledge gaps. Secondly, to foster networks across sectors and jurisdictions, and I'll talk about that in my presentation. And thirdly, to provide the public health system, and I'm going to add there, and our collaborators and our partners, so those in other parts of what we in the Community Health Nurses of Canada would consider to be that larger community health space, with an array of evidence-informed resources and knowledge translation services. So webinars, workshops, conference presentations would sit in that knowledge translation service, but also working with jurisdictions and organizations kind of on a one-on-one is also one of the things that we do as what we might call a knowledge translation service. Our focus at the National Collaborating Centre for Determinants of Health is on the structural and social determinants of health, in particular around how to close that gap or how to promote equity, health equity. So I wanted to start today in maybe a more negative place, and hopefully end on a hopeful and positive space in about 20 minutes. And I've got a couple of Slido polls that I'm hoping are going to work, that I'm going to ask you to respond to in a couple of minutes. But Kathy Baxter provided some really strong leadership through the Community Health Nurses of Canada. And we mounted a survey of nurses about 15 months into the pandemic. So these results reflect that point in time. 245 community health nurses answered the survey, and 82% of them reported experiencing moral distress, which, as you can see there, is defined as arising when one is unable to act in accordance with their moral judgment. So seeing something to be wrong or not good and being unable, even though you know how to act, being unable to be able to act, and would give rise to moral distress. I think one of the most significant findings of that study is that 50%, so of the 82%, 50% of those that reported moral distress said that it was either distressing, intense, or the worst possible. So it wasn't light moral distress, it was deep moral distress. And what we wanted to do in that study was explore how the inequities, so I'm going to tie it to the sort of concepts and ideas and notions that I was asked to speak to. But we really wanted in that study to explore how inequities in populations that community health nurses across country had been working with, wanted to work with, were unable to continue to work with, how that contributed to their experience of moral distress. And in the study, there were 7 themes around that contributed to or were sources for the moral distress. And there's a few here that you're going to hear as I move along. So that there were unmet needs going into the pandemic, that we knew that there were unmet needs as community health nurses. Saw the impact of, well-intended, evidence-informed public health measures, but saw the impact or the disproportionate impact of those public health measures on populations. That one size absolutely did not and does not fit all. I hear someone with a mic open and a bit of noise there, so maybe they could close that mic. That the quality of care that the community health nurses were providing, they felt was suffered as a result of, and that gave rise to moral distress, and that they were in a space of constant and never-ending change, and just sort of coming at them, that change. So that sort of sets the context. So inequities were there, inequities widened and intensified, and it caused and gave rise to, I think, some pretty serious moral distress. And this was 15 months in. So I don't think that abated or eased as we moved on through the pandemic. So I want to talk a little bit about equity, and I'm going to start with a poll question, and I'm going to go to the poll in just a minute and hope that it works. But when you think about equity, what is one word that comes to top of your mind when you think about health equity? And there's the QR code, and also you can just go to www.slido. And you type in that number, 9206003. Okay, and we have one participant typing. And what this is going to do is form a word cloud. And I think I saw that there were about 150 of us in the room. So I'd like to see us get, well up there to 70. 75, you can see what people are typing in here. So what's that one word when you hear that word equity or health equity or social equity? We've got about 40 people who've put in their answers. So just sort of stay here for a little bit more. So you see the word fair, you see the word fairness, you see the word justice, you see social injustice. Interesting though, you've got opportunity, access, opportunity, again, decolonization, human rights, imbalance, racial equity, so a very specific part of that equity. Interesting, really interesting. Assisting, so some of the solutions that are coming through here is listening, resistance, discrimination, inclusion, awareness, respect, kindness. Yeah. Thanks. Thank you. So we have a number of products, and I'm going to promote our products because we think about you. We think about the workforce, the public health workforce, but also the community health workforce whenever we're writing or thinking about, and we have engaged with many of you in the development of these resources. But we just refreshed or revised our Let's Talk Health Equity. And in it, we have a definition. It's also reflected in our glossary of terms that's on the National Collaborating Center for Determinants of Health website. But equity means that all people, whether we're talking about individuals, groups, populations, communities, and there's the word, have fair access to and can act on opportunities to reach their full health potential and are not disadvantaged by social, economic, and environmental conditions, including socially constructed factors such as race, gender, sexuality, religion, and social status. And I often put this word here that it's aspirational. And last Friday, I was making a presentation and a woman who spoke after me said, it's not aspirational, Claire. It's our lives. It's real. Inequities occur every single day of our lives. She was speaking from her community of a Black population in Nova Scotia. And so I think she actually found the word aspirational to be a bit offensive. And I stepped back and I reflected. So why do I put aspirational there? Because I, Claire, do not want to be challenged by somebody, basically, if I'm really honest, who says, well, that's not possible. And I soften it by saying, well, it's aspirational. So as you can see, I've crossed it out and I'm going to leave it crossed out. So that's what health equity means. But to achieve that, it means that we have to understand that it's not the same as equality, absolutely not the same as equality. And that the only way it's going to be achieved is by reducing or eliminating the differences in health status between groups that are a direct result of structural and social factors that are modifiable and can be changed. It's going to take huge effort and collective effort, but they can be changed. And we've seen evidence of those being changed. But it means that we acknowledge that some people have unequal starting places. And therefore, back to that findings from the moral distress survey and study, one size doesn't fit all. And actually trying to make one size fit all is, in fact, exacerbating the problem and not acknowledging that some people have unequal and some populations, communities have unequal starting places. So inequities, which is the other side of the coin from equity, is defined as differences in health that are associated with structural and social disadvantage. And I think that word is important because it acknowledges that many of us have advantage. So it helps us, I think, to remind us and to see that. They're systematic, they're avoidable and modifiable, and they're unfair. And that's what makes them an inequity. And as I said before, they're rooted in social, economic, and environmental conditions, but they're also rooted in power imbalances and in how we choose to redistribute our resources, or distribute our resources, and our power. And it often results in groups who are already experiencing disadvantage being at risk for even more poor health outcomes. So just a little bit about that systematic. What that means is it's not random. You see a pattern. We've seen those patterns for years. We see those patterns in our data and information, but we also hear it in stories, and we also know it from our practice. It doesn't take very long in practice for us to see that these differences are not random, and they exist at every socioeconomic level of society. They're avoidable and modifiable because they are a result of how we distribute resources, how we distribute opportunities, and what we tolerate and leave unattended. And they are modifiable through collective action with cross-societally, cross-departmentally, intersectorally, however we want to look across and see that collective action. And they're unfair, and you had fairness and fair and justice and just and social injustice in the words that came to your mind as you thought about the word inequity. And so they're connected to our values, our personal values, our organizational values, team values, to our neighborhoods and communities within which we work and engage. And when something is connected to values, it requires a moral judgment, back to that moral distress and back to that inability to act on that moral judgment. So inequities, of course, are going to give rise to that sense of powerlessness or moral distress. And it requires a commitment to social justice and to basic human rights. And you had those words in that word cloud. I like this illustration because it goes to that place of justice, and that place of justice as the solution to inequities and inequalities. So you can see the people, the two people there in the top left-hand corner, but you can see that those apples are not distributed in the same way across the tree. There's more on one side than there is on the other. Equality would be to give everybody the same chance to get immunized down the street at a immunization clinic, or universal service provision. So there's those two ladders, they're the very same, so representing equality. But the one person still can't reach those apples, and even if they did get there, they're not equitably distributed, if you will. Bigger ladder, so trying to address the issues of equity, but in the justice slide there at the bottom right-hand corner, using those structural levers, using those things that only through collective action, and I'm going to suggest through positive disruption, that we can actually use those levers, the ropes to pull that tree over, the boards to push that tree in a more balanced perspective, and then being able to see and grow those apples more equitably across the tree. So it takes multiple different ways to get to equity. And then, there's a bit of debate out there right now, and I don't want to spend a lot of time here, but there are different types of determinants of health, both structural and social. A bit of debate about how to talk about them, but this is where we've landed at the Collaborating Center for right now, that those structural determinants are the processes through which the inequities are created, and they would include political, cultural, economic, and social structures, our natural environment, land and climate change, but also the history and legacy of ongoing colonialism and systemic racism. And Karen, I appreciated your land acknowledgement, but also your commitment on behalf of the Community Health Nurses of Canada to working to change these processes, and at least to acknowledge them and to work to change them. And those processes then shape the conditions of daily life, which we know as the social determinants, whether it be education, work, aging, income, housing, or health systems, which we all work within those health systems. So one of the things that is used a lot, you hear a lot, and I'm not 100% sure that people are talking about the same thing or have done the deep reflexive thinking required to really understand what we mean when we use the term intersectionality. And my belief is that nurses, wherever they find themselves in systems or whatever community they find themselves in, have the authority, they have the accountability, they have the responsibility to actually practice using an intersectionality approach. I don't think we require permission to do that from anybody, but it takes reflection, it takes learning, it takes conversation. And so we have a Let's Talk and resource that we put out with our best thinking around intersectionality and from those that we could tap into. And we've held 2 webinars, and we will hold future webinars around this. And we'd certainly be pleased to speak again in more detail about this. I'm just going to be really high level here. But intersectionality is a lens through which you can see where power comes and where it collides, where it interlocks and where it intersects. It's not simply that there's a race problem here, a gender problem there, and a class or LGBTQ problem there. And this is Kimberly Crenshaw really speaking from a critical race theory perspective. But you can see that reference back to power and where there's that interlockingness or intersection of it. It considers how systems, so those larger structural systems, how those things such as racism, classism, sexism, homophobia, and other forms of discrimination, and I would add oppression, where they overlap, where they intersect with one another. And I know that you have seen this in your practice and heard those stories from the families and communities that you work with. So it means that from a discrimination in inequality, as a practitioner, you would seek to identify and address those processes, right? Back at that higher level of marginalization, again, requires disruption, because we're in those processes and we're used to them. And I think at sometimes I become quite desensitized to how I contribute to and use that really colonized way of approaching our work. And so it's about fighting discrimination within discrimination, sort of peeling the onion, looking at the inequalities within inequalities, and protecting or working with minorities within minorities. And then finally, that there is no such thing as a single issue struggle, because this is Audre Lorde, because we do not live single issue lives, and that disproportionate burden of those inequities make this, an absolutely multiple and complex issue lives that families and communities and populations find themselves in. So somebody's mic is off again. So the concepts here are that humans' lives are complex. They're coughing. So we could put the mic or close the mic again. And cannot be reduced to single characteristics. So again, back to there's no one size does not fit all. One single solution is not going to do it. And that social identities can shift as context shift. And that people can actually experience both privilege, but also including advantage and disadvantage at the very same time. And that the forms of power and oppression, they interlock, interconnect, and they reinforce each other. And so it requires us to prioritize social justice, to disrupt, and I put the word positively disrupt, systems of oppression. Calling them out is one of the first ways that we can do them, but that requires that we see them and that we actually identify them, and we're actually able to call out or call in when you see that. To be able to center and engage with people in a meaningful and respectful way from historically oppressed groups. So that would include First Nations, Inuit, Métis peoples, but other racialized groups, sexual minorities, and people with disabilities. And that to recognize that communities are heterogeneous and that populations across our country are not the same, and not to make that assumption. And therefore they have diverse needs and they have diverse experiences. And I'm going to suggest that where we need to start individually, as teams and collectively in organizations, is with values. And this is one of our Let's Talk series that we put out, I'm going to say about maybe 2 years ago now, just as we were maybe 2, even longer than that, about Let's Talk Values and Health Equity. And I like this slide and this graphic, in that, in the center is kind of the goal, right? Health equity and a dignified life. We all want that I think we share across populations. And that first circle out is kind of those desired states of existence. And in that wordle, you had kindness. We have here love, wisdom, self-determination, social justice. You had that as well, including health equity and a dignified life. That next circle out would be values that you see in actions and behaviors that you can be held accountable to. You can hold yourself accountable to those. And it includes accountability, but you had some of these in there too, around respect and trust and humility, honesty, fairness, reciprocity, compassion. And then as you move out in that circle, where you see values-driven or values-informed policy and program approaches. So that would include intersectionality, using an intersectional approach, cultural safety, practicing from a decolonized or decolonizing place or space, disability justice, trauma-informed care, working to promote anti-racism, working to promote racial equity, to disrupt white supremacy in our systems and in ourselves. Okay, so another poll question, top of mind then, what values are most important to you in your practice or role, whether you're at that point of care or whether you're in a more decision-making kind of a space or policy? So the poll is active. You can see that QR code there. I don't see anybody in there yet. Are you able to get in?
Claire, someone's asked if you could repeat the question.
Okay. Yeah, I can't see the chat, so that's
Yeah,
repeat this. What values are most important to you in your practice or in your role?
looks like the Slido's not working. It's says the poll is not active. It keeps bringing us back to Q&A.
Okay, so maybe let's use the chat. Just put into the chat what you, let's just go there. Dignity, compassion, respect, safety, very interesting one, empathy, kindness, cultural safety, collaboration, humility, respect, yes, community-led, inclusive, inclusion, fairness. Thanks. So keep those going as we move along here. My slides have got stuck again. And I don't know why. So keep doing that. I'm going to go out for a minute and my thing have I frozen or am I still okay?
No, you haven't frozen, Claire.
My slides have frozen though. Okay, I'm going to stop sharing for a minute. Okay, and then I'm going to go back in just 1 second here. Technical, right? I think the Slido slide tricked me a little bit here. Okay. And I'm going to share screen again. Okay, am I okay again now?
Yeah, I can see it. You just have to, yes, there you go.
Okay, perfect. Okay, so one of the things that I think about, so you answered that question in the chat box around values. And when I talk about values, I think about values, I often go to my own values. But I think it's really, really important, and I'm going to come to my final point, my slide in a few minutes, that really looks at organizational values. And I think that's a space where we can move on system transformation. And so here's, this is a Canadian, these are Canadian researchers, and you probably recognize some of their names, but this was an article published in 2020 that says values are not enough. And so even though they have health equity identified as a system value, and I would challenge that many of the organizations that we find ourselves working in do not even have that. But then that health equity needs to also be a strategic priority. There needs to be health equity prompts or considerations integrated into all decision making. There needs to be support for those that would be considered to be health equity champions. And there needs to be a look at how we allocate resources. So one of the things that we heard at the National Collaborating Center for Determinants of Health is that we need to know how. It's fine for you, Claire, to talk about concepts and theories and research and this and that, but we really, really need to know how. And so during the pandemic, during the last couple of years, we went about developing what we called a repository of equity in action stories. And there's 13 online right now, 7 in production, and we'd be open to doing more. But these were stories at a team, community, organization, partner level about how these teams put equity in action. And so we lifted this as evidence, not in the research yet, not in the literature yet, but evidence. And we also did an analysis of the themes across those 20 stories. And you won't be surprised. Leadership and organizational commitment was absolutely essential. The recognition that health equity is everyone's job, not just point of care, not just over there in that other department, but everyone's job. And it would take the collective effort of all of us to do that. That interventions and solutions were tailored and that they had the authority to be able to do that co-development, that co-creation. And that they had time, commitment, and the capacity to do the community engagement, the real meaningful community engagement that was required to really take equity seriously. They're excellent stories, and the folks that told us the stories are open to others connecting with them. So if you Google equity in action stories, you'll come to our website and find that repository. The other thing we did is we decided that we would use what we consider to be a fairly innovative KT strategy, and that of podcasting, thinking about our audience and how they might want to access or consume evidence, if you will. So we're really proud of the first season. Season 1 is finished. There were 6 episodes plus 3 bonus episodes, we called them. And so there's 9 podcast episodes up on our website, but you can also get them through Spotify, Apple, and other ways that you might want to consume or access podcast. But I thought, and I'm proud of this, and it wasn't my idea. It was, I have work with an incredible team, and they really wanted to talk about disruption. And they wanted to call the podcast Mind the Disruption, because it's about paying attention to the disruption. It's about caretaking of that disruption. It's about helping to bridge that gap, if you will, between disruption and the more mainstream or formal system. But it's about people who refuse to accept things as they are, about people pushing for better health for all. And it's about people like all of us, and I believe that with all of my heart, who have a deep desire to build a healthier world, and they were able to do something in terms of disrupting the status quo. And in each episode, there is a response, there's a guest that tells the story, and then there's a responder from public health, from the formal public health system. And it's really, really grounded in the belief that change is possible and that we can all play a role in that change. So they've got season 2, and I just met with them yesterday, the team, and they want to focus on social movements for social justice. And I said, I love it. Go for it. So stay tuned for season 2. There'll probably be 6 episodes in season 2. The topics that they want to talk about and where they think that, that persistent and organized effort, what is a social movement, that it involves mobilization of large numbers of people to work together to bring about what they believe to be beneficial social change, or resist or reverse what they believe to be harmful social change. So that's what season 2 is going to be focused on, and really highlighting the 3 core elements of what a social movement is about. So collective action, having a common purpose, and working towards change, which to me goes right back to those 3 parts of the definition of equity, in that they're systematic, they're systemic, they're systematic, they're avoidable and modifiable, and they're not fair, they're unjust. So a little bit about power. And these are just 3 places where there's been strong calls for shifting power, and many of these you'll recognize. Ottawa Charter, 1986, talks about empowerment, whether we like that word or not, power is in there, of communities and their ownership and control of their endeavors and destinies. 1986. In 2008, one of the key principal actions or principles of action from the World Health Organization's Commission on the Social Determinants of Health was redistribution of power, money, and resources. And finally, in an excellent, excellent paper you can find on the National Collaborating Centre for Indigenous Health's website, our sister organization, talking about a vision to transform Canada's public health system, says that we must recognize and address power dynamics and work towards power sharing. Martin Luther King talks about power as the ability to achieve a purpose, and whether or not that purpose, or whether or not power is good or bad. And we tend to shy away in some ways from power and thinking about power, but really it's about the purpose, whether or not power is good or bad. So just a challenge that we have power in our roles and in our organizations, and we have the ability to use that power to achieve a purpose. This is just some key findings from the literature that basically says that, power, thinking about power both at an individual and group level, that actually can build a better society, and that we would actually see it in improved health and improved health outcomes. We put out another Let's Talk, actually just within the last few weeks, and it's on redistributing power to advance health equity. And in it, we profile one framework, power framework. And this really, really resonated with our team and with our staff. And we're going to hold a number of workshops, one in July coming up, one in September, not been promoted yet, so watch for it and please sign up for them, and we'll hold them until there's, the interest in them abates, if you will. But we'll also work with individual organizations if you're interested in doing a power analysis and thinking about power from these 3 faces. But the first is visible power, how people are organized, where we see resources, where there's visible decision-making areas. That's mostly where we tend to think. Hidden is in that relationship, the long-term structures, the networks or organizations, the building of that, if you will, capacity amongst all of us to actually shape agendas and achieve shared goals. And then the third, and that tends to be the most invisible, that's really in that terrain or in that space of what I'm going to call values or ideology or worldview, or how we understand why we are where we are, and those moral judgments and moral decisions, and the negative effect of not being able to act on our moral judgment of moral distress. So join us for those. And I want to end by sharing our positionality statement. And again, this was not my idea. This was the idea of our team, but in particular, Jonathan Heller and Miriam Richards. And they suggested that we write a positionality statement. And I would suggest that you could do this as an individual, but you can also do this as a team or an organization. And it's in that Let's Talk Redistributing Power to Advance Health Equity. And so what we were trying to do here, or what we are doing here, is recognize that we hold power. We're a small organization. We're maybe a team of between 8 and 10 people. We're on a grants and contribution agreement with the Public Health Agency of Canada. But we have power in various forms, knowledge. We have a funding structure. We are federally funded. And we have access, and so do you, to various agenda setting, whether they're meetings, conferences, organizations. Join the Community Health Nurses of Canada, where we can bring our ideas, our thoughts, our disruption, our positive disruption to them. And that by acknowledging our power and by stating the values, there you can see them: humility, compassion, solidarity, accountability, and justice. We can hold ourselves accountable as individual team members, but also as an organization and within the systems that we work to those values. And that we will make a commitment to support the work of structurally disadvantaged communities as initiators, as collaborators, and as equal partners. So again, holding up what it is that we are wanting to hold ourselves accountable to. And that we believe that public health, one of the most important roles would be to work to redistribute that power if we're going to achieve health equity. So thank you. Please connect with us. There's our QR code. If you want to sign up for our mailing list, I think there's about 3,500, 3,600 who are on our mailing list, and we welcome any and all of you to join us. So thanks for the opportunity, and I wish I was with you in person.
Thanks so much, Claire. And now we have another team member that will be doing the taking questions and answers. And over to you, Genevieve.
Thank you, Karen. My name is Genevieve Curry, and I'm the co-chair of the Leadership Standing Committee from CHNC. And I want to thank Claire for such an amazing presentation. I will use the word that it was very powerful in a good way, but certainly is making me think about the roles that we have and how we take things for granted with our power and our advantage, but how we need to work differently and more collectively, like you said, for social change. So certainly in the chat, people have commended you on your resources, the infographics that you've provided. Some people have provided some other links there. There's some excellent resources there, it looks like, with NCCDH. And if people want to put any questions in the chat, I think we just have a few minutes, but I know our Leadership Standing Committee had a question for Claire, who works with us on that committee. But we were wondering, how can frontline nurses enact some of these ideas of positive disruption in their workplace and with their work with communities? If we could start with that, Claire.
Well, if you go to that repository of stories, and if you go to the podcast, you will hear you'll hear stories of disruption and positive disruption. And I'm not so sure that those people started out to disrupt, to be really honest with you. They saw an issue. They knew something needed to change, okay? They knew that they had some ideas and some solutions, and they started there. And, they followed the way. And I said earlier that it was in collaboration, but it was in true, genuine partnership and collaboration, and probably more like followership of the community, that each and every one of those stories, you'll hear in each and every one of those stories that they followed the lead of those with lived and living experience, whether it was the community members, community organizations, community organizers who are out there working with communities and with people. And so it was in that collaboration, in that cooperation, and in that co-development that each and every one of them started. And someone somewhere in their organizations let them do that, gave them the space to do that, and trusted them that they would do right and do well, and that they were working in a good way, if you will. So I would say my advice would be to start. When you're seeing stuff all the time, start. You'll be amazed where things will go and who will come on side and how that will work. The other thing that I found in my career, and I ended up being the president of the Canadian Nurses Association, like, who knew? I mean, who knew that I get tingly over that I actually would, in the end of the day, have that opportunity. But it started by getting involved with, and it actually was the Community Health Nurses of Canada. I found myself in a conference, in a meeting, and I was telling Sheila Blackstock yesterday, she's one of the new co-leads for the National Collaborating Centre for Indigenous Health, and I think she's in the audience, that I remember going there to the Community Health Nurses of Canada. I was in a really difficult work environment at that time, and I remember saying 3 sentences in a row and nobody stopping me or disagreeing with me and actually nodding their heads, and I thought, oh my gracious. So find your allies, find your people, find those that'll come on side with you, whether they're a cheerleader or whether they open doors. And, it's, for me, it's the best $75 you can spend. Join and support CHNC to do its work. Get involved in your professional associations or get involved in community organization boards. Hear those stories, listen deeply and hard, and then use your voice. Use your voice. We're credible. People want to know what we think. Say what you think, what you've heard. So I think it starts by getting involved, getting outside of what might be comfortable, being uncomfortable, embracing discomfort, and moving ahead.
Yeah, thank you, Claire. I'm just going to, I know we only have a few minutes, Karen, but I'm just going to, there's a question in the chat. And it reads, just thinking about the concept of disruption, how can we work to address the inequities that arise from Western colonial approaches to ways of knowing which value evidence-based knowledge above all other forms of knowing or knowledge? And then this person goes on to talk about how we've set up nursing and how nursing works, certainly around that evidence-based knowledge lens. I know that's a huge question, Claire, but is there anything you could say to that in just a sentence or two or a few sentences?
Well, I'm going to go to some experiences I had as the president of CNA. We were writing, wasn't a vision, it was more of our brand for the Canadian Nurses Association. And what had been brought to us by the consultants was some of the words that used compassion, caring, working with the community. And as we met with the nurses across the country, many reacted to that and said, but we bring science, we bring evidence, our decisions are evidence informed, really wanting to pull up that other side, right? But as I listened to them, and I think Tim Guest, who's the current CEO, we had probably 50 meetings, virtual and in person. It's the both and. It's the both and. Like, don't forget the other sets of evidence and knowledges in nursing. So I just spoke to the profession of nursing. Don't forget the other side of that. And we are trusted by communities. That's a privilege. But I guess the other part I would say is learn. Just keep learning. And talk and work with our First Nations, Inuit, Métis, partners, collaborators, those that are among us, and listen hard and learn a different and better way. It's an evolution. It really is an evolution. And I think we're on a good path. We need to really keep on that good path. They had a big meeting yesterday around retention, and it struck me with the federal chief nursing officer. And I don't know what was talked about there, but it struck me that as I was preparing for this, doing good and meaningful work with and on behalf and in collaboration with community makes you want to stay. I think it all fits together in its way. So I don't know if I answered that, but
I think you answered it beautifully. Thank you. I'm just going to turn it over to Karen for some closing remarks. And people are wondering in the chat, Claire, if the slides can be shared. So maybe, and I see a hands up, thumbs up from you. Karen, we'll turn it over to you. Thank you.
Great. Thank you so much, Claire, for sharing. And thank you everyone for coming and staying. I know everyone has busy work lives, for making space for this time for your own learning and taking it back to your teams. The presentation has been recorded and it will be posted on the CHNC website. It does take a bit of time as we are a small but mighty team, and that will be available on the website, and the other recordings from past webinars are there as well. Just want to give an opportunity as I close for those who may not know the work that's going on at CHNC. There's some wonderful work underway. We're moving along with great momentum. Things are coming together, and sharing the infographic of the standards of practice as a good learning tool to discuss and work with teams, students, your own professional development. And this year we're working on the CHNC standards of practice. A scoping review is underway. We'll be working at how to integrate and update the standards. The CHNC home care competencies, we're in discussion and moving forward with the terms of reference to update those. And as well, working as a member of the advisory committee with a group that Claire and others are leading in the Public Health Core Competency Modernization Project. So a lot of great work and discussion there that the CHNC will be sharing, and wanting to hear your voice and wanting you to share your stories of how you make the competencies come alive in the work that you do every day. And with all of these tools, we really want to engage folks that do the work and provide the input and how do you go forward. So you'll be hearing more if you on our website and on our newsletters of how this work is progressing, and opportunities to be part of focus groups and discussion to move that forward. So thank you, Claire, so much. Our information here for social media. Have a great rest of your day. Thank you for showing up. Thank you for being courageous and being here, everyone. Take care.